This again is a kind of slightly controversial slide. You'll be getting the hang of it that I am kind of controversial every now and again. Here we have our responses to our survey of waiting lists on waiver programs. Now, being a kind of a newcomer to America, I was brought up on the idea that there was no such thing as waiting lists in America. I thought this was a kind of a factor of socialist countries in Europe. There are waiting lists in America. States report them despite Olmsted litigation. And so we're probably underestimating here the extent of waiting lists, because this is what states tell us they have. A caveat to this: there's variation in what states call waiting lists, and people from Texas will tell you that the waiting lists in Texas are a list of people who have expressed a desire for services. They may or may not be eligible for Medicaid, blah, blah, blah. But the question we ask them is, how many people are on your waiting list for waivers? This is what they report. And for some people in America, this will be shocking and a surprise. Very finally, and here's evidence for policymakers. We attempted to estimate the public cost of waivers against institutional care for the different target groups that waivers cover. Now, the reason why we selected waivers was that waivers only give services to people who have been assessed as having an institutional level of care need. So this gets around the arguments of people who say, well, you can't judge the cost of people on waivers against institutional care because people on HCBS programs aren't as high a level of need as people in institutional care. We've cut that argument out by comparing apples with apples, and here we have a target group by target group assessment or estimate of the cost savings of treating people or serving people on waivers as opposed to institutional care. And when you multiply the per participant saving by the number of people on waivers, we estimate that waivers save the public purse in America $40 billion a year in 2002 costs. Here's some evidence for people like Peter Kemper, people like policymakers, people like politicians. In conclusion, the evidence that we've tried to amass and present in this project has shown that there has been a welcome growth in Medicaid HCBS expenditures and participants. That growth has, however, been uneven between the Medicaid programs. It has been uneven between states. We know that some of the reasons why that growth has been uneven between states is due to factors that we have some control over. This is not an ideological point, it's not a political point, it is evidence-based in systematic, rigorous research that has been peer-reviewed and published. This is the message that has to get out. We know from Mitch's work evidence about the cost of unmet need for Medicaid home and community-based services. The estimates is there. We know from evidence that state officials report that many groups, despite the growth in Medicaid HCBS, are not covered or not covered adequately. We know from evidence that we've constructed how much the provision of Medicaid HCBS saves the public purse when compared to institutional care. We know also that only 30 states provide the state optional personal care program. We don't exactly know why that is the case, but we know evidence about why some states provide more HCBS than others. And it's this evidence, I hope, that some of you will take away and work on and use in conjunction with Mike Oxford's normative case for expanding Medicaid HCBS. Thank you very much.